Thank you, Dr. Arun Garg and your wonderful young and dynamic team for inviting me. This is my first time at the World Neurosciences Summit. I've been hearing it's a great meeting, and indeed it is. Thank you very much. The topics also are very interesting. I was going through the program. I did not put the first line. The first line said, picking up the right gun. Now, we dementia experts don't pick up guns. We are very compassionate and we spend a lot of time talking. And like Dr. Suman said, we ask them, is it disinhibition? Is it depression? And so we've been practicing neurology like that. But I think the time has come when we are living in really, really exciting times. The gun that Dr. Thomas, Dr. Netravati have been talking about are in we have to now pick up those guns. So I think the big guns of neuroimmunology, stroke, all those people. I mean, I was there when the first thrombolysis was given in Nizams in Hyderabad, and I remember in 2002 or 3 how worried 7 neurologists were looking into the patient while that IV TPA was being given, and we were also worried. This is a moment like that for dementia. There are 3 drugs that have formally been officially approved by the US FDA for Alzheimer's disease. So the topic is actually very good. So I'd like to thank the organizers for bringing this up. And there are many young neurologists here for whom this won't be a big thing, right? You've been giving TPA or giving rituximab, so you have to give some more MABs for Alzheimer's disease. But this disease is still a young disease in India. Even in the 1990s, if you did the door-to-door survey, dementia patients were not found. But today we know that 7 out of every 100 people, like the chairperson said, have Alzheimer's disease and dementia. And so in the busy neurology clinic, more and more now we are asked, is there a cure? Can it be prevented? What are the treatment options? So we are beyond just diagnosing. We have to try and prevent it. There is evidence. It's been some exciting research that has happened across the world in the last 20 years. So this is a classical presentation of a person with memory loss, then language disturbance, and then difficulty in handling tools, medial temporal atrophy, we say Alzheimer's disease. But you just heard from Dr. Suman that there are some patients who have behavioral problems, who can't speak very well, primary progressive aphasias. Some people who can't see very well. They can't do this KMAT. They can't recognize famous figures. So these are all atypical dementias, which could be frontotemporal pathology, could be any other pathology. So the first gun I will maintain is still a good cognitive test. That will never really go away. So, but you need to do it in the right languages and all of that. And all that has been done by our generation of people. But when we studied 100 patients who had very atypical dementias, not the classical Alzheimer's disease, in Cambridge when I was probably your age, and we found there were Alzheimer pathology in these people who actually presented with other things. They couldn't see well, they had behavioral problems, all of that. So that last line in that brain paper that I wrote, 2007 this is, development of more specific biomarkers is needed. So we have now entered the era of biomarkers for dementia diagnosis. And what are these biomarkers? There have been, since it's been more than 100 years since Alzheimer's described Alzheimer's disease, but we know that beta amyloid aggregates in the brain and forms insoluble plaques in the brain. But there's also tau pathology, synaptic dysfunction. There can even be inflammation. More and more we know that it's an inflammatory disorder. There could be vascular dysregulation. There could be neuronal injury, neurodegeneration. And there could also be coexisting TDP and alpha-synuclein pathology. So these are the biomarkers: A-beta, tau, synaptic dysfunction, TDP, inflammation. So these are the tests that all of you will be ordering very soon to find out what kind of dementia your patient has. So it's a paradigm shift from a clinical to a biomarker-based diagnosis. So it's now called the ATN, A for amyloid, T for tau, N for neurodegeneration. So these are the criteria. They could be in brain imaging, CSF, or blood. So if you have a person with very mild memory loss, MMSE is not bad. This bank officer looks quite similar to this nurse. Both of them have mild memory loss. Both of them have MSA 25. Then you do an FDG PET. The first gentleman has medial temporal hypometabolism, this lady does not. So these are biomarkers of neurodegeneration, MRI and FDG PET. They're non-specific, but they indicate there is neurodegeneration. So that's the first biomarker that we use towards diagnosis. But now we have an arsenal of options, and I'll quickly go through them. You can see from 1984 till now how these biomarkers have developed. The core ones are A beta 42, which is a toxic amyloid that gets deposited in the brain, and then intracellular deposits of neurofibrillary tangles. The complexity is that they don't all come at the same time. I think even in multiple sclerosis, we know in any disease really, different biomarkers, amyloid accumulates first, then tau, then the brain starts atrophying, then you get cognitive decline. So this is and some amyloid accumulates, but then after that it doesn't accumulate beyond a certain stage. The brain is full of amyloid, but the disease progresses. So it has set into cascade something else. So where your patient is on this curve will determine the pattern of biomarkers. So when you say amyloid PET, now this is something that is being done in most research centers across the world. So if a person has memory loss and there's amyloid positivity, it is likely it's Alzheimer's. If you're thinking of an atypical disease, like I said, posterior cortical atrophy, there's amyloid in the brain, it's Alzheimer's. Any early onset dementia with strong family history, you want to know what is the pathology, amyloid PET positive, it's Alzheimer's. But even normal people can have amyloid in the brain. So if you start doing amyloid scans for people and they are normal or they have some mild inattention, it does not predict who will eventually develop clinical Alzheimer's disease. So this is a caveat. Similarly, you have CSF biomarkers. So as amyloid beta accumulates in the brain, it comes down in the CSF and plasma. However, CSF tau will go up. So you do a combination of, there are several phosphorylated taus that are being used. P181 was used, but now currently it's P217. So all trials are using P217. But I had the opportunity of speaking with a person who's actually working with tau pathology in the brain in one of the universities abroad. And she said, this is not the final word. There might be other biomarkers, but for now, P217 is the key word, with A beta 42, NFL for neurodegeneration, and glial fibrillary acidic protein for astroglial activation. So your diagnosis is going to be based on a combination of these 4 biomarkers, which we do in NIMHANS and we've published. In addition, you have neurogranin, you have mitochondrial protein and other biomarkers that we also do, which suggest a multifactorial pathogenesis. So when do we use these biomarkers, plasma biomarkers? If a person is symptomatic and they're negative, it's a low chance of having Alzheimer's disease. If it's positive in a symptomatic person, high likelihood. In clinical trials, an absolute must. No trial is done without doing biomarkers. And then people are talking about it as a diagnostic test. It's still it's being used, but the last word has not been said on it. Similarly, progression, monitoring treatment response. Now the open label extension of all the trials have come out, and I'm not going to present all the data, but you must really read all these trials. It's very fascinating history in the making. And as the drugs have been stopped and you're continuing to watch these patients, again amyloid is building up, so it can be used for progression. Now they're talking a lot about it as a screening test in primary care. Well, we should watch before we start using it, because we still don't have, 1 in 10 is only diagnosed in India. So we are not going to be doing this test in the primary care. I definitely don't think we advocate it, but this is what is being advocated elsewhere. I won't go too much into the challenges. I'll quickly go. I just want to give you all an idea that you must go back and look at these trials. They kept failing, although they were working in animal models, but for the first time, so we used a lot of symptomatic therapy, but this disease-modifying therapies are all done in the MCI stage or very early Alzheimer's disease. Vaccination was the first effort. but there was meningoencephalitis. But when the patient died, they found amyloid actually come down. So this was way back in 2002, very exciting times. But because of the meningoencephalitis, it went into, it was not being used. Then passive immunization, humanized immunoglobulins for different epitopes of amyloid. And this was the first study, bapineuzumab, where although there was no clinical improvement, patients actually came down, levels came down in the brain. The first FDA approved drug is aducanumab, and you can see that people who received it, actually there was a decrease in rate of progression of the MMSE. So Biogen said it would submit it for the US FDA, but the main FDA panel declined to endorse it. They said it was controversial. All of us had to take sides on Twitter, whether you wanted to give it, didn't want to give it. People resigned from the board of FDA. All of that happened. There were two trials, Emerge and Engage. They reanalyzed some of the data, and again it was resubmitted, and it got accelerated approval. So at that point, there were those people who said, this is too expensive, it won't help, and why are we pushing this? And then more recently, it has even been discontinued. Then other drug that is now doing the rounds is lecanemab. This is a Clarity AD trial. It has very high selective affinity for protofibrils, which are the toxic forms of amyloid. And this is the Clarity AD trial. It's given once in 2 weeks as an infusion and clearly demonstrated that the clinical dementia rating scale, the pink line, slowed down the progress in people who were given the drug. Similarly, cognitive tests, similarly, activities of daily living, amyloid was cleared from the brain. All the amyloid biomarkers showed positive effects. So did the tau markers, which is downstream. And what does it mean in real time? Patients can ask you. If a person reaches a certain level of clinical dementia severity by 18 months, when on lecanemab, they will take 25.5 months. It's about a 6-month delay. That's the kind of delay we're talking about. But then you have adverse events. They're called ARIA, amyloid-related imaging abnormalities. About 12% develop edema and about 17% develop hemorrhages. Not all of them are symptomatic and they do resolve with treatment. So this is something that it's now looking like. I went to this panel in the Alzheimer's Association. There was a stroke neurologist, a cognitive neurologist, a neuroradiologist, a geriatrician, and a psychiatrist, and the drug company, the SI or Biogen, all of them who are case by case we are discussing. So say a person is on lecanemab and they develop acute worsening. Is it a stroke? Is it lecanemab-induced edema? I can see Thomas is getting very excited here. I'm sure he will probably give very many lecanemabs in his life. But, so these are causing edema in the brain and they are causing hemorrhages in the brain. And people with ApoE4 allele, which is homozygous, have a higher propensity for bleeding. And then finally, very recently, there is the donanemab trial, which is the trailblazer. You have trailblazer as 1, 2, wherein 3, 4, 5, the 5th trial is going on. And even these patients declined much slowly compared to placebo. And this was just received approval very recently. So lecanemab, January 26, 2023 in USA. September 25th, 2023 in Japan. And I was talking to my colleagues in Japan. They're giving it to patients. 1 in 10 patients of theirs is eligible. Not all will be eligible. And they're just routinely giving it in. And then this is yesterday when donanemab received approval from UK. So you have USA, but not through the NHS. So it can be given in private patients. It is cripplingly expensive. So any money that you have for the patient's caregiver, for the physiotherapist, for the speech therapist, will all go away in $20,000 a year into this for these drugs. So this is all food for thought for all of you, for all of us when we start practicing. And there are many other strategies that are being done, that are being tried against the tau protein. So these are all the tau stabilization, aggregation inhibitors. And then you have microglia activation inhibitors and immunotherapies which are targeting tau. And then you have familial Alzheimer's disease, which is autosomal dominant. So there are these cohorts of families of people who have an autosomal dominant gene. So many of these trials are actually being tried: DIAN, ADAD, API, A4 clinical trials. They're all being done in people with familial history of genetically confirmed Alzheimer's disease. So you can see these are all the range of drugs. So that was the gun. Now this is a bigger gun, non-pharmacological treatment. Patients really improve with cognitive stimulation therapy. Anybody who has or spoken to a patient and tried them to get them to use their brain again, gardening, singing, cooking, talking to their neighbors, dancing, all of these have an impact. Nobody is going to spend millions of dollars trying to get this evidence. But if you are in the clinic and if you have seen patients, you will see that really it is working. And this is, in my opinion, a really big gun for all of us to use. And then environment. This is another gun. If you change the environment, patients become better. Environment, whether you change the way the bedroom is. We have now one thing called a dementia design studio in NIMHANS, which has been, and so we are developing a suite of solutions for people so that they know how they can change their environment so that person with dementia is safe, enabled, and empowered to engage with their activities of daily living. So, what does it mean for clinicians? Like any other neurological disease, we want to be as early as possible, to be as specific as possible. Still, there is no awareness. We need to create awareness in the community for dementia. We need to make a correct clinical diagnosis with our tests. Then we need to identify type of patients who you might think will benefit from lecanemab or any of these MAB treatments. And what does it mean when they're spending so much money? For what is the meaning of clinical meaningfulness? That has to be explained to them. The safety concerns have to be explained. 83-year-old fragile person comes with a bleed. You have to talk about that. And then how do we evaluate treatment response in our own settings? And then, of course, regulatory processes in our context. This is Delhi, it is close to regulation, and I'm sure all of you, some of you here will be asked to provide your opinion on this. So, this is important, and most importantly, cost. And again, it is dividing the world. There are rich people who are going to get it, and the poor people will not even get a diagnosis. So, which raises a lot of ethical issues in our own practice. So, and these trials have not been done in India. So, do we want to do clinical trials? So, this is something that we wrote, a call for clinical trial globalization with a group of other people from the global south. So, the future looks like at the community, it is still screening for cognitive impairment and prevention. At primary healthcare centers, it's to rule out secondary causes, make a clinical diagnosis, counsel them, and then in district hospitals and brain health clinics that we have set up in every district in Karnataka now, do we want to use biomarkers there? This will be the question that we will ask. And finally, in tertiary care centers, therapy. So we've come a long way from running a memory clinic. We now have the brain health initiative in Karnataka, where every district has a brain health clinic with a multidisciplinary team. Our health ministers announced that their dementia will be a policy priority. So we have to move with policymakers as we move along and get the right treatment for our people. And the final gun is prevention. This is the Lancet Commission that came out just, I think, 10 days back. So we wrote about all the new risk factors. So in addition to low education, these are 45% of all dementia risk can be reduced. So we don't even have to wait for developing dementia. 45% of risk is modifiable. And in addition to diabetes, hypertension, obesity, smoking, low physical activity, poor social engagement, two risk factors that we have added are poor vision. So you have to correct vision to improve cognition, and then cholesterol. So there are these are the modifiable risk, 14 modifiable risk factors for dementia. So with this, I'd like to thank all the people that work with us, and thank you.